Good afternoon, I'm Swami Iyer. We are the second day of SOHO, and I have with me Dr. Gaya from Spain, from Barcelona, Spain, who has a very relevant and interesting abstract that she's going to talk about today. But we thought we'll have an informal chat about her topic for presentation, which is at-home management of adult patients following consolidation for acute myelogenous leukemia. Welcome, Dr. Gaya.
Thank you very much.
So tell us, this is a very practical and relevant topic. How did this idea come about? What prompted this?
The idea comes from our program with the autotransplant patients, which started a lot of years ago, I think at 2000. And we have a lot of experience with these patients, and a very good experience with almost 200 patients. And we thought in adapting this program to the autologous transplant program to the AML patients receiving consolidation, because they are similar. They have quite similarities, the neutropenia, the risk of infections, and we have all the structure with nurses, specialized nurses, so we decided to start on this.
So I would imagine that you're doing this for many reasons. One is the main patient-related, the patients who have been treated with induction, who go into remission, and have a good bone marrow, and they've been for at least 4 to 6 weeks in the hospital for the prior treatments. Now they don't want to see the hospital, right?
Yes.
And so that's good quality of life for them.
Yes, there are a lot of reasons. One is the improvement of the quality of life of the patients, and which is evident. The other the other point is the reduce the exposure to nosocomial pathogens, so the risk of severe infections. And the other thing is the economical part, because they are is cheaper than having the patient admitted in the hospital.
So tell us more about it. It'd be interesting to see how you studied these patients and your methodology on your patient. How you studied this, how you went about doing this. I understand it's something you started in 2011, and you have about 47 patients.
Yes, we started in 2011. Now we have 47 patients, which implied 96 cycles, because every patient receives 1 to 3 cycles of consolidation cycles, depending on the risk group. The patients in this at-home management group were treated with mitoxantrone and cytarabine at the beginning of the study, but the rest of the last group of the patients were treated with a high dose of cytarabine and the addition of pegylated GCSF. Yes, and this is a difference, because a difference that we see comparing with the control group. The control group is formed by patients, by the historical group of patients. So we collected the clinical data of patients managed at home, but as outpatients. And the difference between outpatients management and at-home management is that outpatients management, in the outpatient management, patients have to go every 3 days, 2 or 3 days, to the at-day hospital in order to perform the lab test and the transfusion and all these things. And if they have fever, they have to be admitted. And with the at-home patients, a specialized nurse
who would go and visit them.
Goes to visit them at their own houses, perform there the lab test, the CBC management, and all this.
So the CBCs are drawn, the blood is drawn at home, and sent for the lab testing. and
Yes.
somebody checks on it. And
Yes, I checked the results, and I decided if the patient needs a transfusion. If the patient needs a transfusion, the patient have to move
to the outpatient.
to the outpatient clinics. Yes, because we cannot do transfusions at home for the moment, and the patient comes back. And another thing is that we have to support a support unit, which is composed by the outpatient clinic, and we have also a room in the hematology ward, which is available 24 hours a day, in order to attend patients in case of transfusion, for example on weekends, and also in case of complications, fever or bleeding. Patients have to come immediately if they have fever or bleeding, and they are evaluated immediately by the hematologist who is on duty.
So could I ask, how many times would the nurse go home and check on the patients?
More or less every 2 or 3 days.
I see. So it's not every day. Okay.
It's not every day. The nurse contact every day with the patient by phone, but and every 2 or 3 days, depending on the needing of lab tests or transfusions, she moved to the patient's home. And also it depends, maximum 3 days, because all our patients receive intravenous Ceftriaxone using an intermittent infusion pump. And the stability of the Ceftriaxone was 3 days. So this is the maximum for between visits.
So obviously they would go on prophylactic antibiotics, and you use Ceftriaxone as the prophylaxis.
We use oral levofloxacin, oral posaconazole, and intravenous Ceftriaxone.
See. So what have you found so far in terms of the complications and the need for transfusion?
We see that the results were very, very good in these terms. In our control series, we had 86% of febrile episodes, in all cases needing readmission. So there is
fever almost all the time. Yes.
Yes. So it was very difficult to manage for the clinics. And with the patients in the program, we have 29% of febrile episodes, and needing readmission only 4%, only 4 patients, because only 4 episodes need readmission, because if one patient have fever, this 29% of cases that patient had fever, they are assessed in the support unit, and if the patient was hemodynamically stable and did not present focal infections, treatment could be continued at home. We changed the antibiotic, we changed Ceftriaxone, and we started meropenem, plus teicoplanin or amikacin, depending on the clinics.
The need. So you've seen a big drop in the febrile episodes.
Yes.
You've managed at home with this kind of prophylactic antibiotics.
Yes.
Okay, that's very good.
Yes. In the case in the control group, we use also levofloxacin or ciprofloxacin at that time, and fluconazole instead of posaconazole, because it's a historic control group, so times changes, and we introduce posaconazole now instead of fluconazole. But more or less, the oral prophylaxis was the same, and the big change was the introduction of Ceftriaxone, simply.
So that made a big difference, you think?
Yes.
What kind of infections did you see for those, the 29% of the patients?
Yes, we see the most frequent infection were Staphylococcus.
Staphylococcus still.
Yes.
Is it line-related Staphylococcus?
Yes.
That's what we're seeing as an emergence, yes.
Yes. And more or less half of the patients who had, in half of the fever episodes, we had a positive blood culture, and in almost all the cases there are Staphylococcus. We saw one resistant E. coli.
Okay, so that is the ESBL, extended spectrum beta lactamase E. coli.
And we saw 2 Pseudomonas, 1 resistant.
And how did they do, these patients?
We treat one of these patients need readmission, is one of the patients that needed, because it was unstable, and the other could continue the treatment at home with ertapenem or with ceftazidime and amikacin.
Excellent.
With the infusion pump.
How about transfusions?
How
often were the transfusions? Were they manageable?
Yes, but well, the most problem is platelets transfusion, because some patients are a little bit refractory, and some patients need every 2 days. But in other cases, it was about every 4 or 5 days. And about regarding red cells transfusion, more or less 1 per week or something like this.
Any serious bleeds or
No.
complications?
Any serious bleeding, any fungal infection, so no problems in this sense.
Sounds like you have a very strong team, so you have a multidisciplinary team in the hospital and also the home.
I think that one of the most important things is the nurse team. They are very specialized nurses who work in the clinics, in the hematology ward, with transplant patients, lots of during.
I'm sure this would go very well here, because a lot of administrators would want to try and keep patients out of the hospital. But from an economic perspective, 2 other things that you mentioned, one from a patient quality of life and economic perspective, what have you seen so far?
We didn't analyze this point yet, but it is supposed to be very important. Yes. Moreover, in our country, in Barcelona, when drugs are administered at home, are paid by the global healthcare system, and they are not paid by the hospital, by the department. So for our bosses, this is very
Very good.
important.
Okay, so you say the hospital saves a lot of money.
Yes. The hospital saves a lot of money. The healthcare system, well, the bed is free, because in the control group, because of readmissions, it results in a total of 754 days of in hospital days, and in the at-home management group, only 30 something.
30 days. So 30 days was a 730. So that's huge number of hospital days. Yes,
2 years of
exactly.
occupation.
That's outstanding.
So it's very important, and moreover, you not only improve the quality of life of this patient, but you also can admit another patient who real need the admission to receive a treatment or something or whatever. So it's a win-win.
That's very good. So I guess you're trying to keep patients out of the hospital, and only the ones who need to be in, the real sick ones, you do so, and that's good for everybody.
Yes.
Well, excellent. We would like to hear your abstract later this afternoon, and congratulations on the work.
Thank you.
And so a very practical point we forget about managing AML patients. It's very complicated sometimes, and it's a teamwork. I think patients can get good care even at home.
Thank you.
Thank you very much. Thank you, Dr. Gaya.
Thank you.